Today's topic is non-union intracapsular neck femur. Definition of a non-union in general, where the reparative process has halted, defined by Cave in 1958, or a particular fracture not united in the time it normally unites, but it cannot be uniformly applied to all bones. In the 1986 FDA panel definition defined the non-union as minimum of 9 months have elapsed after injury and no progression of signs of healing for last 3 months. But this also cannot be applied universally to all fractures. There are some other definitions for the non-union neck femur. Untreated fracture for 3 weeks, or untreated for fracture for 6 weeks, or no evidence of healing between 6 to 12 months after injury, universally acceptable, and it was defined by Burns et al. In 1976. End result of all these fractures is pseudoarthrosis or a false joint formation at the fracture site. Old or untreated fractures are late presenters. It is a unique problem in our country, causes the problems in management. Neck gets absorbed and limb becomes short. 3 weeks to 3 months termed as a late presenters. These fractures in time blend with those fractures which are termed delayed or non-union. Coming to the incidence, garden type 1, type 2 fractures going for the non-union are rare. These are undisplaced fractures, usually heal. Type 3 and type 4 fractures go for the non-union and incidence is almost 20 to 30%. Accuracy of reduction and security of fixation had the greatest influence on the union rate, and as the age advances, the percentage and the union rate declines sharply. The difference in union rate in young adults with a high velocity injury and elderly age group with a low velocity trauma is as high as 62%. With the improved treatment of acute fractures, the incidence is same as those on elderly patients. But the incidence even after improved treatment is almost 10 to 20%. Why is non-union common after fracture neck femur? It is because absence of a cambium layer of periosteum of the femoral neck that leads to decrease in the healing potential, continuous synovial bathing, and avascularity. As healing callus comes from the neck shaft side, the fracture because of the avascularity of the head. The blood supply is from the shaft side, and very minimum, the head gets minimum blood supply from the head side, from the acetabular side. In the fracture, the blood supply is cut and chances of non-union is high. Factors contributing to non-union of femoral neck are inaccurate reduction, unsound or a loss of fixation, vascular insufficiency, posterior comminution, increased age, osteoporosis, and no treatment. Inaccurate reduction has got a direct correlation with the fracture healing. Fracture healing depends mainly on the mechanical stability and to lesser degree on vascularity. Bone scans have shown that major vascular insert takes place at the time of trauma, not perioperatively. Good reduction means good result. You will get a good result if you reduce the fracture properly. Risk factors for non-union in a cannulated screw fixation are screw fixation in a triangle configuration, displaced fracture, borderline and unacceptable reduction, increased screw shaft subchondral purchase over the femoral neck. The use of an inverted triangle configuration of the screws compared with the triangular configuration increased the union rate. You have to fix it in the inverted triangular configuration. Avascular necrosis and non-union go hand in hand. Avascularity has a great bearing on the outcome of the treatment. Quite few non-unions have avascular heads, but non-union is not always certainly in avascular heads. Incidence of avascular necrosis in undisplaced fractures, it is almost 11%. In displaced fractures, it is almost 4 to 40%. Segmental collapse increases in poorly reduced fractures. Patients with a normal bone stock have a higher risk of avascular necrosis. Methods of diagnosis of non-union and avascular necrosis are, you can detect it in X-rays, bone scan or a CT scan. Sometimes you need an MRI scan also, but good clinical examination and patient other physical parameter evaluation is very important in decision making. X-rays, you have to take a AP and lateral view of the hip, and you can take pull and push views in a non-union case. It shows a radiolucent line at the fracture site, and sometimes segmental collapse or a bone loss you can see in the X-ray. Incidence is undisplaced fractures, it is almost 10 to 20%. Displaced fractures, it is almost 15 to 35%. More in females than in males. 80% occur in 2 years, and it can occur even as late as 17 years. Rises in reoperation after failure of fracture fixation. Incidence is more after second surgery. Bone scanning, it is an accurate way of diagnosis before the X-ray changes appear. You can identify hot spot at fracture site. Uptake ratio for inward femoral head of 90% or less that of the intact side translates into 80% risk of avascular necrosis or a non-union. No study available on proven non-union, but prognostication possible in acute fractures. CT scan, absence of a trabecula across the fracture site suggests non-union. Titanium implants help as they are CT or MRI compatible. But CT scan is expensive. Nowadays it is okay, affordable. High resolution CT scan is helpful. Coming to the MRI, it is useful in non-traumatic avascular necrosis. The dynamic MRI seems to be a reliable, non-invasive, sensitive, specific and accurate method of assessing femoral head vascularity after intracapsular femoral neck fractures as early as 48 hours of injury, and to predict the outcomes of fractures, and may be used as a guideline for the management of intracapsular femoral neck fractures. The sensitivity, specificity and accuracy of predictions of a successful osteosynthesis of femoral neck fractures using this method were 81%, 100% and 89% respectively. MRI classification of early osteonecrosis after fractured neck femur. Type 1 is small infarct in the superolateral area of the femoral head. Type 2, shallow area from superolateral region to fovea. Type 3, large lesion occupying most of the femoral head. Incidence of collapse correlate to the size of the lesion. Sandoz classification. Stage 1, fracture surfaces are still irregular. The size of the proximal fragment is 2.5 cm or more. Gap between the fragments is 1 cm or less. Head of the femur is viable with no signs of avascular necrosis on X-ray or MRI. The presence of a good sized femoral head fragment allows good hold of the implant while performing internal fixation, and very little resorption of the neck and absence of avian promotes fracture healing. Stage 2. The fracture surfaces are smooth and spherosed. The size of the proximal fragment is 2.5 cm or more. The gap between the fragments is more than 1 cm but less than 2.5 cm. The head of the femur is viable. The freshening of the fracture surfaces by drilling or curettage while performing open reduction is indicated along with the bone grafting in stage 2. The proximal fragment is big enough for good hold and stable purchase by implant, hence suitable for osteosynthesis. Stage 3. The fracture surfaces are smoothened out. The size of the proximal fragment is less than 2.5 cm. The gap between the fragments is more than 2.5 cm. The head of the femur shows signs of avascular necrosis. The presence of any of the later three, that is proximal fragment less than 2.5 cm or fracture gap more than 2.5 cm, or the head of femur has avascular necrosis or placed in stage 3, marks the fracture unsuitable for osteosynthesis. Posterior comminution is a major factor in the fracture healing. present in more than 60% of patients who later developed a non-union. Presence of osteoporosis has a little effect on the bone healing, but in the fracture neck femur it makes the difference. Probable cause could be less or no hold of implants in osteoporotic bones. The incidence of non-union increases as the degree of osteoporosis increases. Untreated displaced fractures almost always will go for non-union unless proved otherwise. Treatment of non-unions. In the non-unions of long-standing duration, the femoral head may retain its normal counter and the cartilage space, and the articular cortex may remain intact. In this situation, healing of a non-union will result in a functional hip. These hips seem to be lucky ones with intact vascular supply via ligamentum teres. The treatment of the non-union depends on age. Physiological is more important than the chronological age. Physical status, ambulatory as well as medical status, viability of the femoral head, amount of resorption of the femoral neck, duration of the non-union, and osteoporosis. Surgeon has to choose from salvaging the patient's femoral head or sacrificing the femoral head in favor of a joint replacement. Coming to the salvage options, if the femoral head is viable and advocate bone neck is remaining, non-unions can be treated by fixation alone or osteotomy plus fixation, muscle pedicle bone grafting plus or minus fixation, cortical bone grafting plus fixation, cancellous bone grafting and fixation, or a combination of osteotomy and bone graft. If the head is not salvageable, then options are unipolar arthroplasty, bipolar arthroplasty, total hip replacement, or a girdle stone arthroplasty. Coming to the fixation alone, could be tried within 6 weeks of injury. Late presenters or untreated fractures, which are undisplaced, are reducible in patients of any age group, provided that head is viable and quality of the bone is good. In established cases of non-union, just fixing the femoral head will not sufficient. Coming to the osteotomy and fixation, you can do a Powell's osteotomy or Dixon's geometric osteotomy, McMurray's osteotomy, or sand angulation osteotomy. Coming to the Powell's osteotomy. According to Powell's, the problem is mechanical rather than a biological one, and it is based on the Powell's classification. Abduction osteotomy at intertrochanteric level is done, and it converts shearing force into a compressive force. Coming to the Powell's osteotomy results, Marty et al. In 1993 reported 86% union in 15 non-unions, and they concluded that in patients under 70 years of age gives a good result in majority of patients, and avascular necrosis without segmental collapse is not a contraindication. You can do this osteotomy even in case of a avascular necrosis, but there should not be a segmental collapse. Coming to the Dixon's geometric osteotomy. Indications: non-union with a viable femoral head, femoral neck, and a varus displacement. Advantages: it is easy to perform, immediate stability can be achieved with this procedure, converts shear forces into compressive forces. In this diagram, you can see the Dixon's geometric osteotomy. McMurray's osteotomy. It is a displacement type of osteotomy. Puts the shaft beneath the head, line of weight bearing shifted medially, makes the fracture line horizontal, shortens the lever arm between the trochanter and the hip, and leads to early osteoarthritic changes. Not practiced, no longer a popular surgery, makes future arthroplasty difficult. Sand's angulation osteotomy. Made distal to lesser trochanter, angulated so as to gain length. Line of weight bearing shifted medially, and it is not that popular. Muscle pedicle bone grafting. Useful in delayed presenters as well as non-union. Insertion of a quadratus femoris muscle to the femur is mobilized with the femoral cortex and is fixed across the fracture site posteriorly. Mayer et al. In 1974 reported 11% collapse, segmental collapse at 2 years, and 90% union rate. Other one is a myoperiosteial grafting. Quadratus femoris pedicle with a strip of periosteum placed across the fracture, mean delay of 7.5 months and 100% fracture union in a mean of 4.9 months. Anatomical reduction is not mandatory for fracture union provided its vascularity has been restored. Muscle pedicle bone grafting. Buxey's muscle pedicle bone grafting. It uses gluteus minimus with a attached bone block and fixed anteriorly, used in proven non-unions with the absorbed necks, and 75% good results have been reported. Patty et al. Used a cancellous cannulated screw fixation with the muscle pedicle bone grafting, and they reported 7% segmental collapse as compared to 32% with the fixation alone in delayed presenters. Cortical bone grafting plus or minus fixation. Fibula used extensively and successfully. Nagy et al. In 1998 reported 80% good results in the late presenters. All bad results were in non-unions. Uses a single screw plus bone grafting and hip spica is applied. Patient presenting as 10 months, as late as 10 months were included in the study. Vascular fibular grafting in treatment of femoral neck non-union. Revision surgery with a fibular vascular grafting and internal fixation is an effective and important option for treating non-union of the femoral neck in young patients without severe preoperative shortening and neck resorption. Cancellous grafting and fixation. Dairley and Dixon reported promising results by creating a window entirely and putting a cancellous bone graft. Nowadays, this technique is not used. And there was one study published in 2011 by Lung and Sen. They reported 100% union and satisfactory clinical radiographic result with a 5 to 7 years follow with vascularized iliac bone graft augmented by screw fixation. You can do osteotomy and bone grafting, and good results have been reported by some authors since long time. As a salvage procedure, you can do unipolar arthroplasty reserved for patients whose life expectancy is less than 5 years. Nowadays rarely done, has many problems like loosening, acetabular erosion, difficulty in removing, dislocation and infection. Coming to bipolar arthroplasty, it is indicated when the acetabular cartilage is normal in young or not so old patients who are community ambulators. It permits adjustable neck lengths, reduces impact loading which in turn decreases acetabular erosion, can be easily converted to total hip replacement. 10-year results are quite gratifying. Total hip replacement. Procedure of choice in patients over 60 years of age regardless of the viability of the femoral head. Used in younger patients with a pre-existing rheumatoid arthritis or an osteoarthritis. Immediate mobilization is a major advantage. Rate of implant survival is poorer than that of reported in most other studies of the Charley total hip replacement in the general population. Component survival free of revision or removal for any reason was 93% at 10 years. Dislocation occurred in almost 9% of the patients. This study was published in 2004. Primary total hip replacement versus total hip replacement after failed internal fixation. When compared with the primary total hip replacement in patients with the displaced fractures, total hip replacement after failed internal fixation does not result in optimum functional or clinical outcomes after 2 years. Decision making in late presents depends on lot of factors. Try to preserve the head at all costs. Factors to be considered are age, bone quality, medical conditions, function and vascularity of the femoral head. Young adults 20 to 40 years, irrespective of the vascularity of the head, try to preserve it. If good reduction can be achieved, neck shaft angle maintained, and if presented within 3 weeks, fix it. If presented after 3 weeks, up to 3 months, fixation plus bone grafting, either cortical or a muscle pedicle bone grafting. If presented after 3 months with the shortening and varus of the head, you can do a Powell's osteotomy plus or minus bone grafting or Dixon's geometric osteotomy. If there is a segmental collapse, then replacement arthroplasty or arthrodesis is an option. If the patient is between 40 and 70 years, he presented within 3 weeks and all factors favorable, fix it. He presented after 3 weeks, viable head, no collapse, fixation plus cortical bone grafting or muscle pedicle grafting or Powell's osteotomy. He presented after 3 weeks or non-viable head or a segmental collapse, you can consider of doing a bipolar, a total hip replacement, arthrodesis or a girder stone arthroplasty. Old age more than 70 years, think of early mobilization of the patient. If presented within 3 weeks, regardless of the viability, choose from fixing it to the replacing it as per the GC of the patient. If presented after 3 weeks, regardless of the viability, replace it either with a bipolar or total hip replacement or a girder stone arthroplasty. Decision making in confirmed non-unions. Young adults between 20 to 40 years, fixation alone will not work. Augment it with a bone grafting or osteotomy or a muscle pedicle bone grafting. Preserve the head as far as possible. If neck is absorbed and head is not viable, then the arthrodesis or girder stone or a bipolar or a total hip replacements are the options. Middle age between 40 and 70 years. If the head is viable and neck is not resolved, then fixation plus bone grafting. Osteotomy if leg is short. If there is segmental collapse, bipolar or total hip replacement. No segmental collapse but evidence of AVN, you can do a Powell's osteotomy or muscle pedicle bone grafting. Confirmed non-union, patient is older than 70 years of age. Bipolar or THR regardless of the viability of the femoral head. Girder stone not done nowadays. Unipolar only if life expectancy is less than 5 years.